Hello future doctors, how are you all? Welcome back to MedSteps YouTube channel. So today we are going to discuss about very high yield topic, that is pancreatitis. As I announced before, we are starting general surgery series. I already uploaded about thyroid lecture. So if you didn't watch that video, go and watch. So today we are going to discuss about pancreatitis. So first of all, what it is? Pancreatitis means it's the inflammation, pancreas getting inflammation, we call pancreatitis. How? You can see here, itis means inflammation. So pancreas is getting inflammation. So why? Because of premature activation of the pancreatic digestive enzymes. Activation of the pancreatic digestive enzymes. Where this thing happening? Within the pancreas. If any premature activation of the pancreatic digestive enzymes happening within the pancreas, then it will lead to auto digestion. I will explain these things in pathophysiology properly. Okay. So because of auto digestion, the pancreas will become edema, then after necrosis, then after hemorrhage, and then after it will lead to systemic inflammatory response, then after sepsis. So these are the step by step approach for pancreatitis. So we have total two different types of pancreatitis. Here so types of pancreatitis. So we have total two types, one is acute, another one chronic, acute and chronic. Okay. So this acute means it will be like sudden inflammation of the pancreas with potential recover you can see. Okay. Chronic will be like long standing inflammation causing irreversible damage. That means chronic pancreas will be like irreversible, acute pancreas will be like reversible. Okay. And the onset will be like, it will be like sudden. Chronic pancreatitis will be like gradual and progressive. And mostly acute pancreatitis, the main cause we can see, that is gallstones and alcohol. Next one, the chronic pancreatitis will be main cause is chronic alcohol consumption and some genetic disorders and like unknown cause, idiopathic, like that. So mostly in acute pancreatitis we can see edema, inflammation and necrosis. In chronic pancreatitis we can see fibrosis, calcification and gland atrophy. So these are the types of pancreatitis, and these are the things very important for our exam point of view, because if you are in general surgery department, if you are doing currently you are doing clinical rotation, means the doctor can ask the difference between these two things. Okay. Next we will see little history of pancreatitis. Here you can see one person is in 1899, in 1889 this doctor we called Reginald Fitch. This Reginald Fitch described acute pancreatitis. You can see here that news and everything. Okay. And in 20th century we find out the relationship with gallstones and alcohol established. In modern era, right now pancreatitis is easily we can diagnose with CT scan, computerized tomography. It will help to severity the scoring and minimally invasive necrosectomy, and it's like evidence based critical care improved based on that CT scan. Okay. So we have some clinical importance in acute pancreatitis. So you can see here this image. The pancreatitis can range from mild self-limiting disease to multi-organ failure with mortality like greater than 30%. Every surgeon one day they encounter with pancreatitis in emergency department or surgical ward or ICU in operation theatre. When I did general surgery department in GPHC, that time I saw many, like plenty pancreatitis patients. Okay, so that's why this is very important. Now, why this pancreatitis is very important? Because this pancreatitis can mimic with many. This pancreatitis can mimic with many other conditions like perforated hollow viscous perforated ulcer or acute cholecystitis, or another one like mesenteric ischemia. Okay, mesenteric ischemia and intestinal obstruction and myocardial infarction. So, if you don't know properly about pancreatitis, then you are going to miss this diagnosis and the patient can go to potentially to fatal. Okay, so that's why this topic is very important. So, if you are doing any Viva or any ASCII exams, if you are getting the question of pancreatitis, the doctors mostly are going to ask about what are the main cause. For pancreatitis will be like gallstones and alcohol cause, and we can see some serum lipase like greater than 3x, because lipase will be like more normal, like lipase will be like 3x, more than 3x, normal is most specific. And we can see contrast CT is the best imaging after 72 hours of the admission. And we can see some in physical examination, we can see some signs also. So, the infected pancreatitis, pancreatic necrosis is the major indication for intervention. Okay, so these are the main high yield exam points. So, next one you can see here little surgical anatomy of the pancreas. So, first of all, pancreas is the retroperitoneal gland. What it is? Retroperitoneal gland, and it extending from duodenum to spleen. So, here we can see some parts like head, neck, body and tail and uncinate process. Okay, so these are the parts of the pancreas. So, you can see some relations. This head, the head we can see like in C loop of duodenum. You can see here, this is the image, it will be like C loop of duodenum. Along with that, in posterior we can see inferior vena cava. I'm looking for one good image, 1 minute. Yeah, so you can see here, this is the inferior vena cava. Okay, so this inferior vena cava we can see posterior to the head of the pancreas, along with that right renal vessels. So, next we can see neck part. In this neck, behind portal vein formation we can see, and the clinical significance is if any patient have portal vein injury, because of this, okay, mostly patient will get head and neck pancreatic cancer and these things. That time clinically it's very important because the portal vein can injury during surgery. Okay, and we can see body. In this body, anterior part you can see stomach, in posterior part relations you can see aorta and superior mesenteric artery and left kidney you can see in posterior of the body of pancreas. Next, tail. In tail region we can see that tail lies in splenorenal ligament and most vulnerable during splenectomy. Okay, so next one, blood supply. In blood supply, first of all we are saying arterial blood supply. You can see in this head region the blood supply we can see like with superior pancreatico-duodenal artery. Okay, so this is the thing, superior pancreatico-duodenal artery is going around this head region. Okay, along with that we can see inferior posterior inferior pancreatic duodenal artery. Okay, in body and tail we can see like splenic artery branches. These are the splenic artery branches will provide artery system to the pancreas. Next we can see venous drainage, the venous drainage through portal venous system. Okay, so these are the blood supply of the pancreas. Next we can see lymphatics. These are the main lymphatic system of the pancreas. So mostly the pancreas will drain to pancreatico-splenic nodes and celiac nodes and pancreatic nodes, and another one we can see superior mesenteric nodes. So, these are the main nodes we can see in lymphatic system, because the pancreas will drain to these nodes. Next we can see nerve supply of the pancreas. Mostly whenever we are seeing about nerve supply of the any organ, we have to divide into two different parts. One is sympathetic, another one parasympathetic. Okay. So, in sympathetic we can see from T6 to T10 everything related to pancreatitis. Okay. So, this T6 to T10 will be like everything sympathetic sympathetic nerve supply, and next one parasympathetic, we can see the parasympathetic we can see with the vagus nerve. So, because of the thing because of vagus nerve we can see severe epigastric pain. Severe epigastric pain, whenever patient coming with pancreatitis, the patient will get severe epigastric pain and it will radiate to back. Okay. So, these are the main things for surgical anatomy. So, next one we can see little thing of embryology. Mostly the pancreas will develop from two buds. One is ventral bud, and another one we can see dorsal bud. So, this ventral bud and dorsal bud, if fusion is fails, then we call that is pancreas division. This is one congenital problem, important cause of recurrent pancreatitis. Okay. So, I am focusing mostly on surgical part because this is general surgery series, that is why. So, we have some surgical landmarks. These are the structures is very important because they are very prone to get risk, okay, while during surgery. So, first one we can see portal vein and common bile duct and superior mesenteric artery and superior mesenteric vein and splenic artery and splenic vein. So, these are the important structures at risk, so during surgery. So, these are the little amount of surgical anatomy. Now, physiology of pancreas. In physiology of pancreas we can see the pancreas will divide into two different parts. The physiology divided into two different parts. Okay. Actually pancreas have two different functions. One is exocrine function, another one endocrine function. Okay. In exocrine function we can see acinar cells. So, these are the acinar cells, you can see here. These acinar cells will produce some enzymes like trypsinogen. Okay, we have it will divide into two different types of enzymes. One is proenzymes and active enzymes. In exocrine we can see like it will produce trypsinogen and chymotrypsinogen and lipase and amylase. And the endocrine function we can see like islets of Langerhans. This islets of Langerhans, it will release insulin, glucagon and somatostatin, and we have some protective measures. Why patient will get pancreatitis means we have some protective mechanisms, like normally we can see trypsinogen. The trypsinogen activated only in duodenum, and we can see acute pancreatitis. This acute pancreatitis occurs when activation happens inside the pancreas. If actually it have to happen in duodenum, if anything happening in pancreas, then only we call the patient will get pancreatitis. Okay. Next, causes of, next we can see here, that is causes of pancreatitis. So, these are the main causes we can see pancreatitis. We have one mnemonic to easily remember. One is the pancreatitis name is I get smashed. I means idiopathic, means unknown cause or ischemia. Next most common cause is gallstones. Okay. Then after ethanol, alcohol consumption, then after trauma and steroids, mumps, paroxysmal or EBV, cytomegalovirus and Coxsackie and these are the things. Okay. Next we can see some genetic conditions also. Genetic factors also can cause pancreatitis. We have total 3 different types of mutation. So, we can the mutation will be like PRSS1 mutation. Next we can see SPINK1. Next we can see CFTR mutation. So, these are the mutations can cause pancreatitis. Another one, some autoimmune problems also can cause pancreatitis, along with that scorpion sting, okay, and hypercalcemia, hyperlipidemia, hypertriglyceridemia and hypothermia and ERCP. And we have some drugs, the drugs cause pancreatitis like azothioprine, valproate and thiazides, furosemide and digoxin. So, these are the things can cause causes of pancreatitis. Okay. Next one you can see here pathophysiology. So, normally we can see in pancreas we can see acinar cells. Okay. These are the acinar cells. So, this acinar cells, if any patient have any triggers like alcohol or more amount of drugs using person or trauma or ischemia or virus, then it will affect the release of intracellular proenzymes and lysosomal hydrolysis, means premature trypsin activation will happen. Then it will activate the other enzymes and then after we can see auto digestion. Okay. Then after we can see inflammation, then after edema, necrosis and hemorrhage, then after SIRS, then after multiple organ failure, then after patient will get death. So, one is with acinar cells, okay, then after it will activate the enzymes. Second one we can see obstruction in patient, if patient have any obstruction like cholelithiasis, ampullary obstruction or chronic alcoholism and ductal concentrations, or because of the thing patient will get interstitial edema, then after impaired blood flow and we can see ischemia. Next one you can see defective intracellular transport like metabolic injury, experimental like alcohol, duct obstruction and delivery of proenzymes, same to same everything will cause and it will acinar cells will become injury, then the enzymes will become activate and we can see some lesions, that is interstitial inflammation of the edema, then after proteolysis, so the protein will break, then after fat necrosis, lipase and phospholipase, then after hemorrhage. So, then at last patient will get pancreatitis. Okay. So, another thing, we have some cellular events. Whenever the trypsin will activate, we can see elastase and phospholipase A2 and lipase. So, these are the main things will cause pancreatitis. One is elastase. This elastase, what it will do? It will destroys the blood vessels and it will cause hemorrhagic pancreatitis. Next we can see lipase. This lipase will cause fat necrosis and whenever you are seeing fat necrosis, you can see chalky white calcium deposits, or you can call saponification. Saponification means, if you are not understanding, means I already made normal general pathology lectures. In that lecture you can see this about this saponification. Okay. So, next one We have total 2 different types of pancreatitis I already mentioned before. One is acute and second one chronic. So, in acute we can see 2 different types of pancreatitis. One is interstitial edematous, next one we can see necrotizing. So, interstitial edematous we can see like mild and most common of acute pancreatitis, and next one we can see necrotizing, it will be like severe high mortality. Okay, necrotizing pancreatitis means it will be severe high mortality we can see. Next one we can see chronic pancreatitis. Why? Because this chronic pancreatitis will be like progressive. Why I am telling like this is progressive? If you are seeing here, this is the pancreas, first it will cause inflammation, after inflammation it will lead to fibrosis, then after the pancreas will become calcified and hard, we can see calcification. Next we can see exocrine failure and endocrine failure. So, the function you can't see, then after it will become progressive and it will become irreversible. Okay. So, these are the acute pancreatitis and chronic pancreatitis in difference. So, next we can see some clinical features of the pancreas. So, the clinical features we can see like symptoms, like classic symptoms, the patient will get epigastric pain, along with that whenever the patient it will radiates to back, whenever the patient is leaning forward the patient will get little relief. Okay. And some other symptoms we can see like nausea, vomiting, and anorexia and diarrhea and tenderness, okay, and abdominal distension. Okay. So, these are the things we can see. Next we have some signs. In that we have some signs like fever, hypotension and tachycardia, and patient will get decreased bowel sounds and severe epigastric pain, and in physical examination we can see some changes in abdomen, and so these are the things we can see. Next one, in signs we can see hypotension also. In abdomen, epigastric tenderness and guarding and ileus we can see. Okay. So, this is the main physical examination. We have some classical signs. You can see here the periumbilical ecchymosis, you can see. Periumbilical ecchymosis means you can say this type of thing in around umbilicus also. Next one, Gray Turner sign. Gray Turner sign means in flank area the patient will get flank ecchymosis. Next one we have another sign, that is Fox sign. I do not have picture because okay. Fox sign means in groin region, in inguinal region we can see ecchymosis, means that type of bleeding spots. Mostly what it indicates means if any patient have hemorrhagic pancreatitis, the patient will present with this type of clinical signs. Okay. So, next we can see here, whenever any patient coming to you, so first of all we have to do history taking, like proper assessment. In history taking we have to ask the patient the patient drink alcohol or not, and if you suspecting gallstones, any previous attacks or ERCP, and drugs, any traumatic incident, or if any patient have family history. And first question we have to ask in pancreatitis, why does pain radiate to back or not, because I already mentioned before the pancreas is retroperitoneal organ and it location of the pancreas. So, in history taking this is the main important we call Socrates. Socrates means we can divide into total site, means where the pain is, the patient getting pain, diffuse and upper abdominal pain, and onset when that pain started, and we can see character of the pain like boring pain and radiation to the back, and any associated factors, means because of the pain the patient getting any other symptoms like nausea, vomiting, dyspnea, and timing like pain escalates into the intensity and peaks within 10 to 20 minutes, it is increasing or reducing, everything we have to ask. Okay. Next we have some, whenever patient is coming to GPHC, first we will do proper history taking, then after we are going to do physical examination. physical examination. In physical examination, if any patient have pancreatitis, first we have to do inspection, next one palpation, next percussion, last auscultation. So, what we have to do? First one, inspection. In inspection we can see distension, abdominal distension, jaundice and ecchymosis. Next we can see palpation. In palpation we can see like epigastric tenderness and guarding. Next we can see percussion. In percussion may reveal ileus also. So, that is why we have to know how to differentiate. Next one we can see in auscultation the vowel sounds will reduce. So, the vowel sounds will reduce. So, this is the physical examination. Okay. So, next we have some differential diagnosis for pancreatitis, because it can mimic this condition can mimic like pancreatitis, that is why. So, first one we can see cholangitis. The patient same pain the patient will get with cholangitis and cholecystitis, but in cholecystitis we can see Murphy sign will be like positive. Okay. Next gastritis. Gastritis will be like we have to ask like when that patient getting pain after eating food, before eating food, like that we can differentiate. Next one, intestinal perforation. The patient have any ulcer before, we have to rule out that thing. Next one we can see myocardial infarction. In myocardial infarction we can check with ECG, so easily we can diagnose the myocardial infarction. Next, pancreatic cancer. Next we can see like in perforated ulcer. In perforated ulcer in X-ray we can see free air, okay, or pneumoperitoneum. These are the things. Hollow viscous perforation, these are the things we can see. And next one, mesenteric ischemia, pain out of proportion. Next we can see peptic ulcer disease. This is the main cause for perforation. Next one, abdominal aortic aneurysm rupture, like pulsatile mass we can see. Next one, pneumonia. Okay, so these are the things, differential diagnosis of acute pancreatitis. Next we can see here, that is investigation. In investigation of pancreatitis. In investigation, the main things, first we have to check with serum lipase, very important. Why? Because for pancreatitis this is the best test, and 3x normal, it strongly suggests pancreatitis. Next we can check serum amylase. This serum amylase will rises earlier in pancreatitis patient, but it is not that much sensitive, it is like less specific. Okay. Next we can see CBC. The CBC we can see like leukocytosis. Next we can see like CRP. In CRP this is the severity marker. Next we can see liver function test. The liver function test, the ALT will be like greater than 150. Then you have to suggest the patient have gallstone related pancreatitis. Okay, so these are the investigation of the pancreatitis. Next we can see some imaging. So in imaging, first you can see here, this is CT scan. So whenever patient coming with pancreatitis, first we have to do ultrasound. Ultrasound is for detecting the gallstones. If patient don't have any gallstones, then we have to do CT scan. In CT scan also contrast CT scan. In contrast CT scan, that is a gold standard for severity assessment, and this CT scan we have to do after 72 hours, because then only we can see this type of edema and everything in pancreas. I am marking here, you can easily appreciate that image. Okay. So next we can see, whenever patient coming with CT scan and everything, we have to, okay, for example this is pancreatitis case, patient, okay, CT scan. So here we can see the pancreas will be like enlarged, and peripancreatic fluid we can see, this is the peripancreatic fluid, and we can see necrosis and collection of collections and pseudocyst. If any patient have any pseudocyst like this, pseudocyst, yeah, like this, if any patient have pseudocyst, you can easily appreciate in CT scan, okay. So good. So why this is important? After this CT scan will guide us, this CT scan will guide to know the severity. Based on that CT scan, we have one score we call Balthazar scoring system. So this Balthazar scoring system, we have total A to E grading used for severity prediction of pancreatitis, okay. Next, so this is not for us, for residents and everyone, they are following this thing, okay. So next we can see classification of we have, okay, if any patient coming to GPHC, we have one classification we called Atlanta classification, okay. Maybe I forget to keep that picture, okay. So we have one classification, the classification we called Atlanta classification, okay. So we have one classification, that classification we call Atlanta classification. This classification is very important. Why this classification is important means we are dividing into 3 different types of severity. One is mild, next one moderate, next one severity. So in mild cases we can see no organ failure, okay. So in moderate cases we can see transient organ failure, but the patient is not that much severe because less than 48 hours the patient will get normal. Next we can see severe case, the persistent organ failure, we can see greater than 48 hours, okay. Next we have another criteria, that is we called Ranson criteria. In Ranson criteria will help for admission the patient, okay. Like this is the main classic exam favorite for in OSCE settings. This Ranson criteria, when patient admitting, that time we will check that bun levels and vitals, okay, and liver function test, and these are things we are going to check. After that, after 48 hours, another time we will check for the patient getting any recovery or not. So this criteria will help to management and admission, okay. Next one we have Bishop score. This is the Bishop score, is the best score for modern bedside severity assessment, okay. For checking severity in bed, around bed, that time we can use Bishop score. Next one we have another score, that is Apache score. This Apache 2 score for ICU severity assessments, okay. So these are the main criteria, are very important. So for doing CT scan, in CT scan Balthazar CT score is very important for knowing for predicting the severity. Next we can see Atlanta classification. This Atlanta classification will help to know the severity of pancreatitis. Next, Ranson criteria will help to in admission time. The Ranson criteria is the best criteria. Next we can see Bishop score. The Bishop score we can see when patient around the bed, in bedside, that time Bishop score is the best score to differentiate to know the severity of the pancreatitis. Apache score in ICU severity assessment, okay. So these are the things. Next we are going to see the management. So whenever patient coming with pancreatitis, first the main principles is we have to treat cause, then after we have to support the organs, then after we have to prevent the complications, then after we have to avoid unnecessary surgeries. So first of all we have to do conservative management. In conservative management, the initial management will be like giving fluids resuscitation, like if you are preferring means we have to go with oral. Oral is oral Ringer's lactate we can give like 250 to 500 ml per hour. Next we can use some analgesics, means painkillers. You can use some fluids, then after you can use some painkillers like morphine, hydromorphine or fentanyl. Okay, then after nutrition. Nutrition is very important for pancreatitis patient. The early enteral feeding within 24 to 48 hours. If patient getting any breathing related problems, maintain oxygen saturation with oxygen mask. And antibiotics we can give, but not routinely, only for infected necrosis, or if we are suspecting cholangitis, then only we have to do antibiotics. Okay. Next one. Next how we have to do surgical management. So in surgical management, if patient have gallstone pancreatitis, we have to do cholecystectomy. This cholecystectomy I will explain the surgical procedure and everything when we are discussing about biliary pathologies. Okay, after recovery. Next we can see infected necrosis. In infected necrosis we have to do drainage or necrosectomy. Next, if patient have any pseudocyst, if patient have some symptoms, if patient have asymptomatic, just observe. If patient have symptomatics, we have to do drainage. If that okay, pseudocyst will be like symptomatic. If patient have infected, if more than 6 centimeters, then after we have to do drainage. If it's persisting, we have to drainage. Okay. Next we have some operative procedures like current gold standard like percutaneous drainage and or endoscopic drainage, or minimally invasive necrosectomy or open necrosectomy only if it's required. Okay. So next we can see here some complications of pancreatitis. So the complications we can see, first one local, another one systemic. In local, the patient complications we can see pseudocyst, necrosis, abscess and hemorrhage and splenic vein thrombosis. So these are the local complications, splenic vein thrombosis. Next we can see systemic complications like acute respiratory distress syndrome, acute kidney injury, and patient going to get shock, and disseminated intravascular coagulopathy and multiple organ failure. Okay. So these are the main complications of acute pancreatitis. So in emergency management, whenever patient admitting to the accidental emergency department, first we have to do primary survey like airway, breathing, circulation, disability and exposure. If the patient indicating for ICU, if patient have any shock or organ failure and severe necrosis or acute respiratory distress syndrome, we have to refer to ICU. So based on recent guidelines, the patient first we have to the recent guidelines, it's showing like we have to start for acute pancreatitis early aggressive fluids, then after early enteral feeding we have to avoid prophylactic antibiotics, and we have to delay the intervention greater than 4 weeks when possible. So the step up will be like minimally invasive. Okay. So these are the things. So in ASCII setting, the most important questions they are going to ask, that is most common causes. We already discussed this everything last, just I want to give recap. So that's why I am discussing about this high yield points. Most common cause of pancreatitis, that is gallstones. Next one, best diagnostic enzyme will be like lipase. The pain will radiate to back, and best initial imaging will be like ultrasound. Then after, if you are not getting any gallstones, then you have to go with CT scan after 72 hours of the admission. Next we can do Atlantic classification. The Atlantic classification will help to find out the severity, like mild, moderate and severe. Next one, we can see Cullen sign. The Cullen sign means periumbilical ecchymosis. Next we can see Gray Turner sign, that means flank ecchymosis. Most feared complication, that is MODS in pancreatitis. Next one, current preferred necrosis treatment will be like step up approach. In ASCII sessions, the exam patient will present with acute abdominal pain. The expected findings will be like epigastric tenderness, tachycardia, distension and reduced bowel sounds. So the main diagnosis will be like acute pancreatitis. If any patient coming with 45 years old male, heavy alcohol intake, severe epigastric pain radiating to back and patient getting vomiting and lipase elevated and CT shows peripancreatic edema, the diagnosis will be like acute alcoholic pancreatitis. So we have to quite the alcohol, we have to counsel that patient. Because of alcohol we are getting pancreatitis. Along with that, we have to manage with intravenous fluids and analgesics and early feeding. Next one, monitoring. Okay, so these are the things. So I mostly covered everything about pancreatitis. So if you have any doubt, you can ask me in comment section. So next we are going to discuss about another topic. So till the time, I am going to sign off. If you didn't subscribe my channel, please subscribe my channel, like, share and comment if you have any doubt. So we will meet in our next video. Till the time, take care, bye bye.